Okay. Let me do first. Hello, Professor. We are the Group 10, and my name is Nike Moon.
Mia.
My name is Serge.
So for our disease, we are the Turner syndrome. Let us discuss it. So for the disease introduction, what's the Turner syndrome? It's a condition that affects only females, results when one of the X chromosome sex is missing or partially missing. And what's called Turner syndrome? The girl is missing parts of all of the chromosome. Certain genes are missing. The loss of these genes leads to the symptoms of Turner syndrome. So how does Turner syndrome process in body function? It may associate with a certain physical and medical features, including estrogen deficiency, short stature, and increased risk of several diseases, with cardiac conditions being among the most serious, such as the short stature, heart and renal abnormalities, hearing loss, and other issues. It's caused by the absence of one set of genes from the short arm of one extreme, and in patients with 45, about 2/3 are missing the partner extreme. So how does it present to the physician? The common signs are short stature and ovarian insufficiency due to ovarian failure. How will we make sure of it to diagnose it? Doctor use a special blood test that looks at chromosomes called a K-test. Result that indicate TS shows only one extra instead of two X, with a total of 45 instead of the usual 46. So here are some tips we need to pay attention. Due to a wide variability in symptoms, some girls with TES may not be diagnosed until the teen years or later, but we still need to diagnose it either before or after birth. For the primary market research, it shows that to keep us with the current TS market trends, we take KOLs and SME opinion working in the TS domain through primary research to fill the data gaps and validate our secondary research. Their opinion helps to understand the validate current and emerging therapies treatment patterns for TS market trends. So in the primary market research, we can see that the demand side includes the doctors, general physicians, and other medical professions. The supply side includes the manufacturer, wholesaler, and retailers. So for the secondary market research, we can see that the epidemiology study, it provides insights about the historical and current TS patient pool and forecast trends for individual 7 major countries, and it may show the competitive landscape. Let me move to my guide.
Perfect. Thank you so much. I guess I'll pick it up from here. What impact does the prevalence of Turner syndrome have? So a couple of things I do want to mention is there was more than multiple studies looking at the prevalence of Turner in general. The earliest one I would say is from 1975 to 1991. It was actually conducted through 3 or 4 different studies, and they outlined the newborn prevalence by performing chromosomal analysis. It was quite a breakthrough study back in the day, but they analyzed the chromosomal analysis from umbilical cord blood samples, and the prevalence number they found was 64 per 100,000 females. A little bit more recent was 2016 to 2019, where we had 2 studies have a prevalence number between 17 to 35 per 100,000 females. It was based on population-based epidemiology study that counted a number of females actually being diagnosed. As I'll later show, that number is a little bit not too precise. However, one study that was more prevalent and new was in 2019. It was actually conducted in Britain. It was a single nucleotide polymorphism array data in blood in the UK. It's usually used as a high-end diagnostic prevalence in mosaic TS women. So essentially, they used a chromosomal analysis data on women that were pregnant. And that data was more reliable as a result. You had more individuals diagnosed or I guess, confounded with 88 per 100,000 females. Kind of getting all these data points together, you can see that there's about 1 to 2,000 people to 1 to 2,500 females or newborns that are actually diagnosed or affected with Turner syndrome. There is a large number of undiagnosed TS women. Some TS women actually, when they do genetic testing for this, they tend to do an abortion. So that is one thing that's not counted in these studies. Couple things. Current data suggests that the prevalence of TS is similar across countries and between ethnicities. So there is no data linking one or another ethnicity or age group to higher epidemiological data. So essentially, you make sure that when you look at the Turner syndrome data, it's spread across majority of the ethnic and age groups. One thing that I want to show you in these graphs is the impact of incidence of Turner syndrome. All three of these graphs are actually from one study, and they showcase the incidence of Turner syndrome according to karyotype over time, and the incidence of Turner syndrome according to karyotype and incidence of graph A was all the women with Turner syndrome. Graph B was every single individual that had a 45 and X Turner syndrome chromosome, and then C Turner syndrome with all other karyotypes across individuals with only one X chromosome per million females during 1970 to 2014. As you can see, majority of these graphs imply that Turner syndrome has been on the rise from the early 1970s to about the late 2010. The next slide does showcase more on the relation to morbidity and mortality. And as you can see, morbidity and mortality are clearly increased compared with the general population. The average age at diagnosis is quite delayed. With Turner syndrome, it's a little bit hard to diagnose these patients. One, the criteria of or the phenotype of majority of these individuals is displayed at later stages in life. So one thing when you're looking at morbidity, the main cause or increase of cause of morbidity is type 2 diabetes in these individuals, congenital malformations of the heart and kidneys, endocrine and gastrointestinal comorbidities, psychosocial problems, and majority of these factors lead to the morbidity of these patients. Mortality, TS has a threefold increase in mortality over age-matched controls. Usually those controls, the mortality is increased across all karyotypes, and it's caused by increases in all-cause death, with cardiovascular disease accounting for about 40% of those deaths. One thing I do want to mention is that congenital heart disease in TS varies on the basis of spectrum of the disease. So it depends on how further off the disease state is. And majority of the individuals diagnosed with congenital heart disease there has been an estimate of about 22 to 70% having a mortality rate. Life expectancy, on the contrary, is actually quite interesting to see. The only study that was mentioned in life expectancy was from 1986, and it was more of an epidemiological community study. And the reduction in life expectancy was about 12.5 years at age 1. And then if individuals diagnosed at age 11, it was about life expectancy of about 20, and then age 10, it was life expectancy of about 40. Average life expectancy, if you look across the spectrum, is about 13 years less than normal individuals have. I guess the next slide will showcase the impact of quality of life. This is a little bit more controversial. Some of the individuals don't have a larger impact because their life is not really diminished as their phenotype is not expressed as often. So it is a little bit controversial, but as you can see, there's a study that was done in 2018, a European multi-center study. It did showcase that 96% of TS patients reported their health status as being fair or better, so about comparable to normal individuals. And 85% found that it was fair or better to live on their present income. So income was not really a social factor. So these individuals had not really an issue of finding work. It's more of how long they can work. 84% had a medium or higher education, so quite comparable to normal individuals. But one thing I do want to highlight is quantitative studies of quality of life in TS women have found that their general well-being is similar to controls or only somewhat compromised, but they are negatively affected by late induction of puberty, hearing loss, older age, a diagnosis, and age in general. And one thing that I do want to showcase as well is the social and humanistic and economic burden of these individuals. Kind of epidemiological studies regarding the social economic in TS, they were a little bit sparse to find, but the positive outcomes is that women with TS had similar educational attainment and income as female controls. However, the negative outcomes, they did end up retiring early due to their phenotypic presentation. They experienced significantly fewer partnerships, and they were less likely to become mothers. Those were all three factors that were more diminishing their quality of life. As we can see, the current treatment options, treating specialties and physicians, it's a little bit hard to just showcase to one physician and say that, yes, this person treats TS. So it's more of a multidisciplinary approach with TS, and it does involve multiple specialties, usually pediatricians, endocrinologist, clinical geneticist, gastroenterologist, cardiologist, fertility specialist, and it really depends on what stage of life TS patients are at that these individuals are involved in. Standards of care is pretty limited in terms of literature, but the most universally accepted therapy is actually promoting therapy, which is GH. It is mostly used in kind of individuals that are still progressing in their growth. So essentially individuals that are younger. So it does have a little bit of variability in terms of how well it is done. But depending on the start of treatment and length of treatment, target height, and other factors, you can usually deduce the treatment modality of this. Usually induction of puberty and treatment with sex hormones for the remainder of normal reproductive period to increase the reproduction of TS individuals is used as well. However, there are no guidelines to proper dosing or route of administration, oral or transdermal, or for estrogenic compounds, or likewise dose and route administration for progesterone compounds. A couple of things associated conditions include congenital malformations of the heart, kidney, like we discussed, endocrine and gastrointestinal comorbidities, fertility issues. As a result, growth hormone can't encompass all of this. It only helps increase the growth spurt, and as a result, other hormones can't do that as well. But early diagnosis does help increase the growth promoting treatment for these individuals. One thing about current treatment options on the next slide, what they do show is that there is a little bit of a deviation in terms of products available currently in the market, and this is more of a quick cost-based comparison on the maximal doses of treatment for Turner syndrome. So as you can see, if you actually take the maximum dose of each of these drugs, whether you look at Sazin, Neurotropin, or Humatrope, or if you look at Genotropin, these are all growth hormone products. Majority of them have daily costs varying about $80, and the annual cost is about $30 to $32,000. However, incremental annual costs compare with Genotropin, that's more of the most common one that's used. They are about 13,000 more expensive compared to the Genotropin itself. But majority of the time, these are the most common drugs that are growth hormones that are being used on the market. And then from there, I'm going to pass it on to my partner.
Thank you. And then I will introduce the measurement, competitive landscape, and opportunity. The diagnosis of Turner syndrome can be divided into prenatal diagnosis and postnatal diagnosis. There are three main methods of prenatal diagnosis. First is photonic villus sampling. It is usually done between 11 and 14 weeks of pregnancy. The test takes small pieces of tissue from developing placenta. The chorionic villus cells can be used for chromosome studies. The test results for fetus with Turner syndrome is the partial or complete absence of one X chromosome 45 and X karyotype. Second is amniocentesis. It is typically done after 14 weeks of pregnancy. A sample of amniotic fluid is taken from the uterus, and it can be used for chromosome studies. The test results for fetus with Turner syndrome is the partial or complete absence of one X chromosome. Third is ultrasound. Certain physical findings associated with Turner syndrome may be seen on a fetal ultrasound. For the postnatal diagnosis, a diagnosis of Turner syndrome is often confirmed by chromosomal analysis, which is usually achieved by determining the karyotype. The blood sample is used to ascertain a person's karyotype. The results for the patient with Turner syndrome is the partial or complete absence of one X chromosome. And next slide. For the market size of target population, because patients with a middle phenotype may remain diagnosis, it is difficult to ascertain the true prevalences of Turner syndrome. However, based on the literature, Turner syndrome is seen in about 1 in 2,000 to 1 in 2,500 live female births. So the number of new births with Turner syndrome per year can be estimated. And we estimated the number of female births with TS in the US in 2021. According to the data from the CDC, the number of births in the US in 2021 is 3.66 million, and the sex rate at birth in the US in 2021 is 1.05. So we can calculate the number of female births. The calculation is nearly 1.79 million. According to the prevalence of Turner syndrome documented in the literature, we can calculate the number of female births with TS in the US in 2021 is about 700 to 900 people. And next slide. We can see the competitive landscape on the left. There is no R&D pipeline in the preclinical stage and in phase 1. There are 3 pipelines in phase 2 and 1 pipeline in phase 3. There are now 6 products approved for the treatment for Turner syndrome on the market. They are all thermotropin. Genotropin is from Pfizer, and Humatrop is produced by Eli Lilly and the company. Norditropin is produced by Novo Nordisk. Neutropin is produced by Genentech. Cyton is produced by Merck Serono, and Zomectin is produced by Ferring Pharmaceuticals. For the R&D pipeline, somapacitan is in phase 3. Somapacitan is a new growth hormone medicine for treatment of low level of growth hormone. The purpose of study is to find out if somapacitan is safe and how well somapacitan works in children with Turner syndrome. And there are 3 pipelines in phase 2. First is vosoritide. The study will evaluate the efficacy of vosoritide in improving height outcomes of children with Turner syndrome. Second is Lunapeg somatropin. The study focuses on investigating the safety, tolerability, and efficacy of Lunapeg somatropin compared to daily somatropin in children with Turner syndrome. The third is YPEG-RHGH. The study tries to explore the optimal dose of YPEG-RHGH in children with Turner syndrome. And next slide. And finally, I will talk about the opportunities. There are some limitations for the current treatment. Growth hormone injection can only improve the symptoms of short stature in patients. It cannot cure the disease fundamentally. Children with Turner syndrome need daily injections of growth hormone, and the growth hormone needs to be stored at low temperatures. And the disease imposes a great burden on patients and their families because of the risk of complications. Regular health checks and preventative care and treatment are important for patients, and the costs of growth hormone injections can put a great financial burden on the patient's family. And this disease impacts the quality of life. Most women with Turner syndrome are infertile. The psychosocial impact of Turner syndrome may be substantial for young girls and women. Girls with Turner syndrome may have difficulty with nonverbal, social, and psychomotor skills. Because of these reasons, there are many development opportunities. So the pharmaceutical company may consider developing growth hormone that can taken orally and store at room temperature. And the biopharmaceutical companies can develop new prenatal diagnoses such as NIPT, and companies can develop gene therapies to cure Turner syndrome. Next slide. There are some references, and thank you for listening.